Right, so we're going to have a podcast on colorectal cancer screening. I'm here with Dr. Bod Goddard, who's lead for colorectal cancer screening in Derbyshire. Thanks for coming today, Bod.
No problem.
I wonder if you could first cover the indications for screening in general, any disease really. What makes a disease suitable for screening?
Well, the main point of screening for a disease is firstly that it's important and that there is an easy test to do which can pick up the disease at an early and treatable stage such that it does not then present later when it's in a more advanced stage.
Mm-hmm.
It's the basic principle.
Right.
So if you look at colon cancer, for example, we know that most cancers probably arise from polyps, and currently when we detect colon cancer, it tends to be at a far later stage. So 2/3 of the cancers we detect in symptomatic patients will be Dukes C or D.
Yeah, so they've spread beyond the bowel and maybe not curable.
Yes.
Yeah, okay. And other things about the disease, I mean, we need to know its natural history, don't we? And we need to have a test that's acceptable and not too dangerous, etc.
Yes, so we have to have a test that's acceptable to the public.
Yeah.
And you're always going to run into problems with bowel cancer screening with that. And as you say, that includes the risks and dangers of doing a test.
Basically, colorectal cancer is a common disease. It's a serious thing. We know its natural history, and we can pick it up early and stop it progressing. So pick it up at an earlier stage, which leads to increased cure rates. So what evidence is there supporting the development of colorectal cancer screening in the first place?
It depends what sort of screening test you're talking about. There are three main ways of screening for colon cancer. There's doing a complete colonoscopy as a one-off or as a repeated procedure, doing a flexible sigmoidoscopy at a certain age, or doing fecal occult blood testing.
Yeah.
Now, there's no evidence really for colonoscopy screening.
Yeah.
There's lots and lots of evidence for fecal occult blood testing, and there's increasing evidence about flexible sigmoidoscopy screening. Now, in the UK, we've gone for fecal occult blood testing, really based on three very, very large studies looking at it in America, in Denmark, and in this country.
In Nottingham, that's right.
And that basically showed that you could get about 60% of people to take up screening, just under
60,
and you would expect to pick up about 2/3 of the cancers at Dukes A or Dukes B stage.
So they picked up an earlier stage, more likely to be cured.
And that the test was reasonably acceptable to the population and was associated with a fairly low level of risks. So what would happen, and what is going to happen with what currently happens with the national screening programme, is that people get sent a fecal occult blood test. If it's positive, they then get offered a colonoscopy, and then, depending on what you find in colonoscopy, you take things from there.
Okay, so and the study showed somewhere between a 15 and a 30% reduction in death, didn't they, from with screening?
Yeah, 19% is the current quoted figure.
Right. Okay. Now, so what age group are screened in this country?
Well, in this country, currently it's 60 to 69, and it's about to be rolled out to up to 74.
Right.
There are a couple of pilot sites, 5 pilot sites around the country, which are doing the age extension.
Yeah.
Now, the trouble with that is that a lot of the trials had evidence of patients from 50 to 74. And in Scotland, they screen from 50.
Okay.
And why we've decided not to do that in England is a slight mystery, but I guess it's a lot to do with the fact that your pickup rate is lower in the 50 to 60-year-olds, and their relative costs of therefore screening that population is much greater.
Yeah. Okay, but the screening now, and we just managed it in a budget we can afford. So. What's actually sent to the patient? What is a fecal occult blood test?
So the one that we use in this country is a hemoccult test, which is a piece of card which opens out to about an A5 size. There are 6 windows on it, sort of 3 sets of 2 windows, and the patient puts a bit of stool on 2 windows, closes that window, puts it on the mantelpiece or wherever. Next time they go to the loo, they do it again, and then again, and then send it in a specially Royal Mail approved envelope.
Presumably airtight.
Many things tight, and that then gets analysed at the lab by basically just putting a bit of hydrogen peroxide on, because it's a guaiac-based test, and that then changes colour to blue, which is a positive.
So it goes blue when you put the.
If there's blood there, it'll go blue.
Yeah.
If there isn't, it doesn't change colour.
Okay. How sensitive and specific is that test? That's one of the things that people talk about.
Okay, it's pretty. It's about. We always thought it was about 50% sensitive based on the trial data.
Yeah.
looking at the results in the national screening programme so far, it's more 60 to 65% sensitive. So we'll pick up 2/3 of the cancers if people do the test.
So you do the test and it's positive. The chances of you...
Okay, so the people who have a positive test, there's about an 11% chance of them having cancer at colonoscopy.
Yeah.
There is around 60% chance of having significant polyps, adenomas over 1 centimetre, or multiple adenomas, and there's about 10% chance of finding something else like inflammatory bowel disease.
Okay, you do the test and the test's negative. You don't have cancer, right?
Mostly, yes. I mean, 49 people out of 50 will have a negative test, and as I say, we'll miss about 35% of cancers. Right. So we do have some people who pitch up having had a negative test with cancer. Now, unfortunately, most of those people got symptoms, and therefore it's trying to get the message across that if you've got symptoms, you need to be investigated.
Okay.
A fecal oral blood test that is negative doesn't mean anything.
Right, okay. Why don't we improve the sensitivity and specificity? There are more sensitive and specific tests around.
The trouble with, if you choose a more sensitive test, you're going to end up colonoscoping more people, and that therefore increases the burden, and it's, we are stretched as a country trying to provide the colonoscopy service.
Yes.
But also that increases the...
What colonoscopy?
Now, though, that varies from study to study. We currently quote around 1 in 1,500.
Yes.
The evidence is that if you've got perforations that are due to polypectomy, a large polyp, particularly if it's over 3 or 4 centimetres, you're more likely to get perforation. More likely to get perforation on the right side of the colon because it's thinner, walled. But actually, as the screening programme so far, our perforation rate has really been about 1 in 3,000. So
right. And what's the chance of dying from this screening study? Because it's the only screening study you can die from, really, isn't it?
Yeah, that's certainly true, unless you've got a very brusque mammographer. We don't know. No one's died, thankfully, yet. Some people have died within the programme having had their surgery, of course, for the cancers that we've detected. But no one's died as a result of the colonoscopy yet. We would expect that the perforation... The mortality rate from a perforation at colonoscopy is around 10%. So, but what we do with this programme is that we phone people up the day after they've had the test, which isn't probably normally done for most diagnostic colonoscopy. So we know at an early stage that people have still got abdominal pain or don't feel well, and they probably get investigated at an early stage, and we have a high suspicion rate. Great.
Okay, so in summary then, colon cancer is ideal because it's a common serious condition. We can pick it up with a screening test at an earlier stage and improve cure rates. The downside is that testing can be expensive when you get over to colonoscopy and can cause complications.
I think that's fair.
Yeah.
The other thing to say is we picked up a huge number of very large polyps before they become malignant.
Yeah.
So we may well see a fall in the prevalence of cancer as the programme rolls out.
So you pick things up even before they become cancer?
Yeah.
Okay. Have we missed anything out?
No, not really. The only thing to say is that clearly this is we still have trouble getting this across to the public. The idea of doing stool tests and then people doing colonoscopy still doesn't receive great warmth, and you don't see people running around in brown t-shirts for bowel cancer charity at the moment. So I think there's still a lot of work to be done trying to get the public involved, and if we can improve our uptake rates, I'm sure we'll do even better. Yeah, people need to be more aware of their symptoms, really. That's probably the best thing they can do, isn't it? Okay, well, thank you very much indeed, Bod, and we'll leave it there. My pleasure.